guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about the medical management of type 2 diabetes. In previous videos, we've talked about medical management of type 1 diabetes, which, if you'll remember, is the inability to synthesize insulin in the body. Thus, the medical management is pretty simple, just replacing insulin through different forms of insulin for type 1 diabetes. In type 2 diabetes, the problem is more that even though you have insulin present, your body is desensitized to the effects of insulin. Thus, the medical management is going to be a little bit more complex. Now, before we dive into the individual drugs that can be used to treat type 2 diabetes, first I want to do a quick recap of the pathway of glucose and insulin in the body, because at every step in this pathway, that is where we have a different pharmacologic agent that can be used to treat type 2 diabetes. Starting off, first we have to digest glucose for it to get into our system. Glucose is going to go through the mouth as food and then into the stomach. Once we have eaten our nutrients and these nutrients have made their way through the stomach and into the intestine, then in the intestine, they have to be absorbed. So this is where our oligosaccharides or our disaccharides like sucrose or fructose have to be broken down into individual glucose molecules for absorption through the intestinal brush border. After we have absorbed this glucose, absorbed this nutrient, and it makes our way through the GI tract, that is when the presence of glucose can start to stimulate insulin release from our pancreas. Remember, insulin is released by the pancreatic beta cells. We'll get into that a little bit more later. And then once insulin is released from your pancreas, that is when it can go exert some of its end effects at the liver, where it is going to promote glycogenesis and decrease rates of gluconeogenesis. Insulin also has effects on fat or adipose cells, where it can stimulate lipid synthesis. And then finally, in the kidney, that is where some of this excess glucose, when it is in too high amounts, can be excreted through the urine. So now that we've done a quick recap of the pathway of glucose and its interaction with insulin within the body, now I want to draw your attention to the handy mnemonic that we have at the top of the screen. STAB, mellitus with DAGs. This will help you remember all of the different pharmacologic agents that we talk about in this video. So the S is going to stand for S-GLUT2 inhibitors. The T is going to stand for our thiazolidinediones. Please don't make me say that 3 times fast in this video. The A is going to stand for our alpha-glucosidase inhibitors. The B stands for our biguanide. The M refers to our meglitinides. The D is for our DPP4 inhibitors. The A is for our amylin analogs, our GLP-1 agonists. And then S is for our sulfonylureas. So they're all the pharmacologic agents that we will talk about in this video. We'll start out at the very beginning, where we are absorbing glucose into our body through our gastrointestinal system. So the first step is when you eat a meal and you are getting some of that energy into your body, that energy is going to have to go through your stomach. And the speed at which your stomach digests that food and the speed at which we have gastric emptying is going to relate to how full you feel. Additionally, arcuate nucleus in your hypothalamus will also play a role in fullness. We have several agents that work at this step. These are your amylin analogs, and the most notable of these is going to be pramlintide. Remember that pramlintide as an amylin analog is going to first slow gastric emptying, so leaving that food in your stomach for longer, increasing the release of the hormones that tell your body it is full, it is not starving, you do not need to be releasing glucagon at this time. And then additionally, it's going to have effects at the arcuate nucleus in the hypothalamus to increase satiety, telling your body that no, we do not need these starving state hormones like glucagon, but instead we can increase insulin release, and that is how amylin achieves its role in the treatment of type 2 diabetes. Now, after you've eaten a meal and this food has gone through your stomach, then we get to the intestinal brush border. And this is where we are going to absorb our energy, absorb our glucose. A lot of glucose that we consume is not in the form of pure glucose, but it's in the form of these oligosaccharides, or multiple types of sugars strung together. One of the enzymes that is very important for breaking down these sugars into types of glucose that can be absorbed is alpha-glucosidase. So alpha-glucosidase is an enzyme that functions at the small intestinal brush border, and its job is to break down these oligosaccharides that are big molecules of multiple glucoses strung together into small individual glucose molecules that can then be absorbed through our GLUT channels, often GLUT5 channels, into the body. If we inhibit alpha-glucosidase with one of our handy alpha-glucosidase inhibitors like acarbose or miglitol, that is then going to prevent your body from absorbing so much glucose at one time and can prevent these really high blood sugars that then cause your body to be overwhelmed because it can't keep up with the insensitivity to insulin that we see in type 2 diabetes. Now, after we've absorbed glucose into the body, the next step in this process, as we mentioned, is glucose stimulating your pancreas, specifically your pancreatic beta cells, to release insulin. And a quick recap of this process, we talked about it initially in the physiology videos, but a quick recap here. Glucose is going to enter into these pancreatic beta cells, usually through GLUT4 channel. Then it is going to go through glycolysis, the citric acid cycle, the electron transport chain that will produce ATP. This ATP is what is then going to stimulate the closure of these ATP-gated potassium channels. And as these ATP-gated potassium channels close, that leads to a buildup of potassium inside the cell. That buildup of potassium inside the cell is going to cause membrane depolarization. The membrane depolarization then in turn causes opening of our voltage-gated calcium channel. The influx of calcium into our cell through the voltage-gated calcium channel is what is finally going to lead to the release of insulin through this cell. So there are a couple agents that work at this step. The first that I want to draw your attention to are the sulfonylureas and the meglitinides. These are both going to have pretty much the same mechanism of action. They're a little bit different, but for the purposes of step 1, you can think of them basically as having the same effect. And this effect is the closure of these potassium channels. Remember, we just talked about how it's the closure of these potassium channels that is going to lead to membrane depolarization, the opening of these calcium channels, the influx of calcium, and release of insulin. So indirectly, by stimulating the closure of these potassium channels, the sulfonylureas and the meglitinides are going to stimulate the release of insulin in response to glucose, which is really going to help us out because although your body is desensitized to insulin in the state of type 2 diabetes, if you have more insulin around, you can overwhelm this desensitization. And so helping stimulate the release of insulin in response to high glucose levels is a really effective way to aid in the management of type 2 diabetes and prevent those crazy high blood sugars, which we know lead to complications such as diabetic retinopathy or damage to your kidneys that we've talked about in other videos. Some important sulfonylureas I want you to be aware of are glipizide and glyburide. I think these are more commonly tested. And then the meglitinides, honestly, these are not tested as frequently, but still important to be aware of. So repaglinide and nateglinide are 2 examples of those. In addition to acting at these potassium channels, there's a couple other drugs that act at the pancreatic beta cell level as well. And to understand the action of these, first we need to talk about the molecule GLP-1. And GLP-1 had several important roles like decreasing gastric emptying, which we talked about in the GI level on this pathway. But here at the pancreatic beta cell, GLP-1 also is responsible for increasing the release of insulin by shutting down and closing these potassium channels. So if you increase the activity of GLP-1, you are thus subsequently going to increase the release of insulin. That's very in detail. Basically, what I want you to understand is higher GLP-1 means higher ability of insulin to do its job. It's like a little buddy to help insulin do its job. We have one class of drugs that basically mimics the action of GLP-1. These are called our GLP-1 analogs. They are exenatide or liraglutide. These GLP-1 analogs or GLP-1 agonists work by closing these potassium channels, thus stimulating the release of insulin from the pancreatic beta cells, and then also acting similarly to GLP-1 throughout the rest of the body, delaying gastric emptying and such. In addition to having drugs that directly mimic GLP-1 and its functions throughout the body, we also have a type of drug that decreases the breakdown of GLP-1. And if you're decreasing the breakdown of GLP-1, you're going to have more GLP-1 in the body. So GLP-1, if you look over here, is broken down into its unusable form or recycled by an enzyme known as DPP4. DPP4 breaks down GLP-1 and prevents it from doing its job of being insulin's little buddy and increasing the release of insulin throughout the body, as well as potentiating its effects. Now, if we inhibit DPP4 and we stop the breakdown of GLP-1, then we're going to have more GLP-1 in the body, and that is going to help release insulin. And that is exactly how DPP4 inhibitors work. Our DPP4 inhibitors are things like sitagliptin, saxagliptin, linagliptin. I like to remember these because they all have this suffix gliptin, which sounds like the GLP stays in, which is exactly what's happening with these drugs. As we inhibit DPP4, we inhibit the breakdown of GLP, and that's GLP-1 is going to stay in and active because we have stopped the breakdown of this product. Moving on from the pancreas, now I want to talk about what is happening in the liver. The liver, there's really only one important drug class for you to be aware of. These are the biguanides. These are probably the most important drug class for you to be aware of in regards to management of type 2 diabetes on step 1, because metformin is probably the most widely used drug for the treatment of type 2 diabetes. Now, the mechanism of metformin is incompletely understood. We don't entirely understand how it works. But one thing that we do know is that within the liver, there is two molecules, M and complex 1, that through their interactions with metformin within the hepatocyte are then going to close down our adenylate cyclase and decrease gluconeogenesis. Remember, decreasing gluconeogenesis is one of the activities of insulin. So by decreasing gluconeogenesis, metformin and the biguanides are aiding in the end effects that insulin would normally be potentiating. A little bit less mechanistic, but equally important, is metformin's effects on increasing insulin sensitivity. Again, this is incompletely understood how metformin achieves this, but it's important for you to know that metformin also inhibits glucagon release, it increases glycolysis, and increases peripheral glucose uptake, which is what makes it such an effective drug to help with the treatment of type 2 diabetes. Now that we've talked about what's happening in the hepatocytes, let's talk about what's going on with peripheral lipid synthesis or lipogenesis. I think the most important thing for you to be aware of in this pathway is that in our adipocytes, in our peripheral fat cells, there is this receptor called the PPAR gamma receptor. The PPAR gamma receptor might show up in a step question, and it's an important receptor for you to be aware of because the PPAR gamma receptor, when bound to its ligand, initiates a cascade, which then results in the downstream effects of activation of the adiponectin gene. Adiponectin is a protein that regulates fatty acid storage, and its downstream effects are going to result in increased lipid synthesis. Although this is a little bit complicated, I'm not sure that you would get tested on this exact mechanism. I think the take-home point here is that this PPAR gamma receptor, when bound, is going to stimulate lipid synthesis. And that is one of the normal results of insulin, right? When you're in your fed state, you should have increased lipogenesis. That is the result of having extra energy around, and insulin should be telling your body to store more fat if you have excess glucose. When insulin's not really doing its job, or your body is insensitive to insulin in the case of type 2 diabetes, that is when drugs such as rosiglitazone or pioglitazone are binding to this PPAR gamma receptor and stimulating lipid synthesis. Now, finally, after we have discussed the pathway of glucose being absorbed into the body, the pancreas releasing insulin, insulin's effects at the liver and on your peripheral fat cells, now let's talk about the excretion of excess glucose through the kidney. So in normal pathology, usually most of the glucose is going to be resorbed from your urine back into the body. Glucose is usually resorbed from the lumen of your nephrons by SGL2. Glucose then re-enters the proximal convoluted tubule and is not going to be excreted as part of the urine because it's valuable, right? We want to keep it around. But in the case of type 2 diabetes, where you have too much glucose in your body that is just floating around in your bloodstream because your body's insensitive to insulin and is not telling your cells to take the glucose out of your bloodstream, it can be beneficial to excrete some of this excess glucose in the urine. That's exactly what these drugs, these SGLT2 inhibitors, canagliflozin and dapagliflozin do. They inhibit SGLT2. And with SGLT2 out of commission, there are fewer ways that your body can resorb glucose out of the lumen of the nephron. Glucose then gets trapped in the urine and it is excreted with the urine. And that's how you can get rid of or manage some of this excess glucose so it isn't just leading to astronomically high blood sugars in the setting of type 2 diabetes. I personally find it helpful that the people who made these drugs gave them the convenient name of that all ends in flozin. If you think about the word flow, it helps me think about urine. And of course, here we are excreting glucose in your urine. So remember, all that glucose is flowing out of the body through the urine. And thus we have decreased renal resorption, which can help combat high blood sugars.